Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, my guest is Dr. Liz Walker. Dr. Walker graduated from the Goldman School of Dental Medicine at Boston University in 2006 and received her certificate in orthodontics and dentofacial orthopedics in 2010. In 2013, she completed an extensive mini residency through TMJ and sleep therapy research, earning a graduate certificate in sleep-related breathing disorders and craniofacial pain. She went on to complete her Master of Science in Dentistry at Boston University in 2015. Dr. Walker has extensive experience diagnosing and treating TMJ disorders and craniofacial pain, integrating both awake and sleep-disordered breathing evaluation into her practice. Her mission is to identify the origin of pain, skeletal, dental, and breathing challenges through state-of-the-art diagnostics and a collaborative whole-body approach. And in doing so, she has built a robust network of interdisciplinary partners, including otolaryngologists, sleep physicians, osteopaths, pediatricians, lactation specialists, primary care physicians, physical therapists, myofunctional therapists, dentists, chiropractors, and fascial release specialists, reflecting her belief in total body wellness. Dr. Walker is also the founder of AirwayZ, an upcoming initiative dedicated to elevating awareness and innovation and airway health. This is a great episode to give you perspective on what it is like to run a practice that focuses on airway health. And some of what we are going to discuss on today's show includes why Dr. Walker made it her mission to focus on advancing airway health and collaborative care, the impact of CBCT imaging on diagnosis and treatment planning, what evidence basis actually is and what it is not, obstacles to dental practitioners providing proactive airway-focused care, and why organizations like the AAO and AAPD, as well as academia, seem to remain hesitant to embrace this concept, how dentists can help to educate our medical colleagues about the importance of pediatric airway health, and much, much more. So without further ado, let's get on to today's episode with Dr. Liz Walker. Enjoy the show, everybody. Welcome to Doc Podcast, Liz.
Well, thank you very much, Mike. It's an honor to be here, truly. Thank you for the invitation.
My pleasure. So happy to have you. We've gotten the opportunity through this and through some other arenas to speak and start to communicate a little bit more on our very parallel existences that it's crazy how many things you and I have in common as we've gotten to know each other and become friends here in the past couple of months. So because of that, I would love, and my audience knows, I love to hear people's stories. Tell me a little bit about how you got to the point you're at in your life and your career. And I know you have an interesting story, having an orthodontic background in your family as well. So you could take it back as far as you want to go to help paint the picture for the audience of how you got to be the Dr. Liz Walker you are today.
Okay. All right. Great. Well, it started out with what we're all familiar with at this point, a little bit of resistance. Actually, I didn't want to become an orthodontist watching my father do it. Okay. But I actually went as far as getting a degree in public relations from Boston University without any science background before any of this became kind of a twinkle in my eye, so to speak. A few conversations with my father and then visiting him at his office once. Actually, I wrote my dental school admissions essay on this little story right here. So I think it's still worth mentioning. I was at his office and still no intention of changing a path that I was on, but he was busy with his patients, came into the back where I was waiting for him, and he said, "Hey, come here. This patient's about to leave. I want to show you." And he pulls me over to the window, and we're not totally stalking her, but we definitely could see her walking out. She got into her car. She pulled down. He said, "I just took her braces off." She pulls down her visor and looks into the mirror and does that big toothy grin, and then an actual bright smile right afterward. Really happy with the way she looks and really thrilled with the process. And it warmed my heart. It gave a validation of a rewarding career that he had really passionately been advocating for so long. And finally, it gave me some permission, I think, for myself to consider a pivot. And I did. I went into, I had to take 2 more years of prerequisites just to get into dental school. than the 4 years of dental school. And by the time I graduated dental school, the orthodontic program was 3 years. So I had to do 3 years on top of it. I really thought when I made that decision, it was going to be a 6-year thing and I'll skip the whole middle management thing. I'll be autonomous. But it took a lot longer than I thought. But I'll tell you, as we know with our parallel situations, everything is in perfect time. Because if I didn't graduate at that time with all of those extra years and extra educations, I wouldn't have hit the airway mark right at that exact same time.
Interesting. Yeah.
So right when I was graduating was when my father bought the CBCT. Of course, I resisted that too. That was like, oh, Dad, we can do the slob thing and see all of it.
Yeah, well, there's still a lot of people resisting that, as we'll talk about in a little bit. So don't feel bad.
No. That's like the best thing that ever happened to us was being able to see 3D. And it wasn't even so much that we could see it, but he went to a users meeting and this got us into Airway. This is
a users meeting for the CBCT.
For the CBCT. Okay. I was just about graduating. He went off to whatever
And about
city.
What year is this?
2010.
Okay. Oh, so he was real early. I was 2014 and I was pretty early. So he was real early.
He was really early.
Yeah. And how long had he been practicing at this point? And not exact, but like 30 years type of?
He was also a little late to the game too. He had a career in textile sales in New York City before he went back to dental school.
You don't hear that every day for textile sales to orthodontics.
It wasn't satisfying. He was doing great, but just really wanted to make a difference. And for all those years he did with relieving pain and obviously inadvertently actually helping people's airways. If you could think, there's still a lot of that is maybe unacknowledged, but
and as a little aside, excuse me, I've gotten to know your dad a little bit through some of the projects we've been working on, and what a great guy and knowledgeable guy, and has a ton of passion clearly still for the profession and for helping patients. And I give so much credit, and again, we'll circle back to this a little bit when we talk about how we can get more of our colleagues to go on a journey like your father did. I give so much credit to people who have been practicing for a long time and are able to put aside their habits, their biases, their way of doing things, the way they run their practice, their systems, and change. And for your dad, 30 years-ish, many decades into practice, to invest in 3D imaging when it really was a bit of an unknown entity at that point as far as what you even do with these machines. We're 15 years later, and we still have the large majority of orthodontists and pediatric dentists and orthodontic residency programs who are resistant to this. So for your dad to be at that point, I just want to acknowledge that, to say it's possible. And those are the type of people we need to look up to, I feel, as a profession, to say we always should be growing and learning, even if we have been doing this for 30 years.
100%. And he is in a similar situation where he has stopped. He sold his big practice. He's still working a few days a week in a smaller practice. This is actually really cool. He's working with a general practitioner. He has teamed up with an internist, a medical provider, and this is a whole...
So general practitioner, you say a medical practitioner, not a general dentist.
Yeah, okay. So the medical practitioner takes the intake and all the labs and all the information and says, next time you come in, you're meeting with Dr. Walker, we're going to get to the bottom of it. I didn't know that, Liz. I
don't know if I've ever heard of that. That is genius.
It's genius. That's another paradigm. It's an alternative. It may be one of the other solutions for us in dentistry as a whole to educate the public, merge it with medicine, bridging that gap between medicine and dentistry with nasal breathing. And because he actually treated this doctor. And so that's how you get people excited about it, is they need to go through they need to breathe it to believe it, so to speak. And coin that right there. You heard it here first.
I'll set that little clip aside for you, so we have an
loop meme. So that was the segue into that business relationship, and it's a brilliant system. So you think about, there's absolutely no marketing needed because the patients are 100% on board. We all talk about how do we get the patient to understand and believe in this before they actually get to, what am I seeing a dentist for? I'm snoring. I wet my bed. I have ADD. ED.
Or even when they're in that exam, why are you telling me this?
Right.
I'm here for my teeth.
Exactly. The whole time that narrative is going on in the patient's head. So that's a huge opportunity that is yet untapped. And like our entire relationship, by the way, is airway. I wouldn't have it any other way.
You and your dad, you're saying?
Oh yeah, totally. It's our friendship. It's father-daughter. It's colleague to colleague. It's like we can't. Neither of us can turn it off when we visit each other. We're literally crickets if we're trying to talk about anything else. Like,
oh, that's hysterical.
Literally, it goes right back into airway. So, and he hasn't stopped. He's actually like just like you, just like myself. When we've pivoted from being in the practice 24/7, you know what I mean by that?
Oh yeah.
The creativity can be unleashed. We can take what our frustrations are and put them into solutions. When doors get closed, that we can open other windows to allow for other opportunities. You with this podcast, my dad with this relationship with an internist, and he's working on other ways to get into groups of the public that are required to breathe easy for their careers. Right?
Okay.
You know, bottom up public to authority angle of getting the world to be educated and then the world to improve their health, and other doctors and medical and dental, everyone to kind of get. So the paradigm is shifting. Mm-hmm. This is just another way in. And that's what we got to keep doing, is finding those cracks, opening those windows and moving forward with that. So that's what he's doing. He can't stop. He's never, ever going to stop. I'm not going to say how far he's into his 80s, but
wow, that's amazing.
He's getting sharper and more passionate about it as he has more time. So yeah, go dad.
That's amazing. Now, did you go into practice when you started practicing? Did you go into practice with him? Were you guys living in the same area?
I did. Yeah, he was living in Boston. I was living in Boston. I was graduating from Boston University. And once again, all through dental school, I'm like, well, I'm never going to work with dad. And of course, it's the first thing I did was that. So he went to this users meeting and for the CBCT, just circling back to that. And this is how the whole airway story begins for us. He was sitting in the audience, the speaker, as you know, Dr. Stephen Olmos.
Yeah, and thank you for connecting us. He was just on the show recently. I got so many compliments and people who reached out to me about that episode. So thank you for putting us in touch. And what a great guy. Just happy to know him.
My sincere pleasure. Behind his mission 100%. Mm-hmm. I learned so much there. I can go on and on about the reflex testing that I learned, the connections with the body. Learning about the nose was just the tip of the iceberg. Mm-hmm. There's just so much more. But yeah, he was our speaker. And when my father was there, I was still in the program. And he said, all right, you're not just going to see some impacted canines and impacted wisdom teeth, but you're going to see the entire airway with this 3D image. And if you're an orthodontist, you're responsible for it. And my dad went, and it just brought to light, because of course the airway's right above the upper jaw, right behind both the jaws. Like, you can't ignore what we've already been doing. And I went to an ENT once, and their resident came in, and I had said, oh yes, I'm working with airway and the tongue relationship and this. And he goes, the tongue has nothing to do with breathing. I went,
there you go.
Oh my God.
And that's that. I have someone coming on in the near future. She's a sleep physician in New York City. And I just had a call with her the other day. We were just talking about concepts for the show. And she literally just said, Liz, physicians don't learn anything about sleep.
No.
So, and there was someone in the doc community. On Facebook, we had a chat going on recently with a great post about treating a younger child. And the occlusion looked really quite good. It was primary dentition. They looked pretty good. Maybe a little narrowing to the anterior and maybe a little high vaulted palate, but certainly good spacing. It wasn't no open bite, good amount of overbite, overjet, really normal sort of relationship of the dentition. No real wear patterns or anything. Things look pretty good, but mom is complaining this child is snoring and has some behavioral issues, which, to all our colleagues, get ready. You are going to hear that and see that more and more and more. And please don't just say, as the ENT said, there's no relationship between
You'll grow out of it.
Right, they'll grow out of it. Right. But the couple of the orthodontists in the group were saying, this is not an orthodontic problem. Get over it. Stop getting your nose into a place where it doesn't belong. And I asked one of them, well, okay, is it normal for a 6-year-old to snore? Again, to your point with this conversation with the ENT. And it's so funny. What made me think of it is, he said, as an orthodontist, I'm not worried about that. And then he said his ENT colleagues are also not worried about that. And that's why they're not taking tonsils and adenoids out as frequently. And so again, we could go so many places with that story. The point being, and I actually replied saying, well, no child should snore. So we should always be concerned if we see a medical issue in any of our patients, whether it's airway related or not. If they had a heart condition, we would be concerned, right? If they had a neurological condition, we would be concerned. If they had a quote unquote syndrome, right? Or a Pierre-Robin sequence or a cleft craniofacial anomaly, we would be concerned. Why aren't we concerned on the airway? And then the other part of that to the ENTs, I said to him, my understanding, because I haven't had many ENTs on the show and I have many as friends and colleagues, they're not doing adenotonsillectomy with the same frequency because it doesn't pay them anything. And the liability is too great versus the reimbursement. So I'm not an ENT. I can't say that's what it is with 100% certainty. I can just relay the messages that my otolaryngological colleagues have told me. And it isn't certainly that there's no need for it or there's no place for it. It's that they really don't want to do it. And I guess the last thing I'll say on that is if they were to quadruple the reimbursement, right, or quintuple the reimbursement, do maybe we think we'd see more tonsillectomy going on?
Absolutely.
I think we probably would, yeah.
But I think there's also a missed opportunity in the diagnostics as well. If your tonsils and adenoids are huge, we can often attribute it to the cold, dry, dirty, unfiltered air that's going through and hitting them directly, right? Mm-hmm. Tissues swell. That's why we have puffy gums even when we floss every single morning and night, right?
Yep.
So if those tissues are inflamed, it's probably because the nasal passage is obstructed, right? So if they could say, I see an opportunity, whether it's a financial opportunity or I'm going to help my patient stay alive.
Right. At this point, well, I'll take either, right?
Either, right? Whatever drives you. It's a real thing. I'm not
we need to talk about it because money is a driving force for, treatments follow reimbursements. It's just, it is what it is for better or for worse.
Yes. So if they were to recognize that could be an added procedure, not only for reimbursement or insurance or whatever collections purposes, but for treating the origin, right? Because if this is a real thing too, how many papers say that adenotonsillectomy is obsolete because it grows back? Well, it's because you didn't change the holes that you're breathing through. You still got a mouth breather at the end of that procedure. And
because the etiology is often multifactorial, and if there's allergic rhinitis and obstruction of the nasal passageways or septal deviation or high vaulted palate, incorrect tongue position, right? I say all the time, the etiology is multifactorial. The solution needs to be multifaceted. And I will keep screaming that from the rooftops.
And maybe multidisciplinary.
And probably multidisciplinary.
Right.
Yeah, I would agree with you. Yeah. I like that. I'm going to add that. Is that okay if I add that at the
Oh, of course. Watermark, Liz Walker. No. No, of course. Use it like everyone use everything. I have come up with all the there's so many little things. Your airway's only as open as its narrowest point. Like a chain is only as strong as its weakest link. You can say the same things over and over because those are the things that hit into a patient's memory or a connection, and whatever works, say it, repeat it, use it. By all means, I'm obsessed with those little ways of clarifying things for people. So yes.
Well, thank you. And I interrupted your story. I'm sorry. So back to the ENT. What was that interaction? What played out with that interaction?
The ENT came in. And because, like I said, it was the resident who said that to me. And once the resident left, he said, well, looks like we got a lecture that we have to repeat for the residents. So that was that. But they're not getting sleep in med school, from what I understand, either. Just like we're not getting in dental school. In dentistry, yeah.
So it's the Dunning-Kruger effect, that curve where the y-axis is confidence and the x-axis is knowledge. And we are looking at the curve to the left on the knowledge part, right? But we are peak confidence, and that's what the Dunning-Kruger curve they call peak ignorance. Because what happens is you have enough knowledge to be able to know, the anatomy of, say, airway or some of these aspects, right? I mean, the ENT certainly doesn't lack knowledge about the anatomy in that area. That knowledge gives them peak confidence. So they're like, oh, well, I know everything there is to know.
I'm the nose doctor. What are you, remember all the jokes that we got about being dentists and not being able to get into medical school and all that? It still kind of prevails in the vibe of that confidence, like you said. But when you said that they know the airway anatomy, I cringed a little bit on that because it goes right back to CBCT. If they're not using the 3D and they're only using an endoscopic view.
Or just using rhinoscopy, which is with kids, the majority of them are literally just using a rhinoscope and turning it up to look from the external, internal, not actually going into it. I don't think many people realize And it's funny you said that. I'm glad you brought that up because I had a debate with when I used to be at Nova, which I'm fine talking about. Many people know I'm not there anymore. And the genesis of that was actually CBCT. I don't think I've even told you this story. No. So I don't think I've told this fully on the air. So it's nothing I'm shy about. But earlier this year, I'd been at Nova for a couple of years, and I'd been teaching a lot about what we're talking about today, airway-focused, earlier, proactive treatment. We were finally, and I knew that the chair and the director, they were husband and wife, didn't agree with a lot of what I was saying, but they didn't really say much to me that I couldn't say things. It just was like, we didn't really talk about this. We didn't really talk much anyway. I was there 2 days a month. So when I started treating patients who were young with the residents and recommending CBCT images and then teaching the residents how to read them, and we started seeing the impact on our patients, the dynamics started to shift, and they started to want to tell residents, I was hearing that they were telling residents, you can't do as many cases with Dr. DeLuke, or we need to stop treating as many young patients. So I'm getting my antennas going up like, okay, like something's going on here. And then there was a case that at that time chair was treating with a resident. And they started treating the child at 5. I've actually talked about this child on the show before little Santi, because it was such a great case, but not in this context, but about how much we were helping him. The patient had, at 5, they had a little bit of a posterior crossbite, really narrow, high vaulted palate. So instead of taking a CBCT, which they have in the clinic, they don't take it routinely, they decided to just put a quad helix in. And so to try to address the malocclusion. Well, a year later, the bite is opening. The palate's higher and vaulted. So the parent couldn't come in on the day that the chair was seeing them. And so it happened to be they could come in on a day I was there. And the resident was excited because she knew that I was teaching about this stuff. So we worked the case up, and turns out we got a CBCT. We uncovered about 80% obstruction of the adenoids, enlargement of the tonsils. We do an airway workup. We find out that he has all sorts of behavioral problems. He's on 2 meds. He's actually seeing a neurologist for meds, which are speed. Essentially, they're putting this kid on high doses of speed, methamphetamine, to try to sedate this child. We have mom take a video of his sleeping, suffocating all night long. He's got the dark circles. He's got like what you alluded to before with, they call them chapped gum, those red, irritated gingiva, all the signs. And so I use braces and wires in these young kids for this. And so we put them in brackets and wires, and we started developing the arches, and a few months go by, and mom comes in one day and she's in tears. She's like, you saved my little Santi. Yep. She's like, you guys are miracle workers. She goes, he is a different kid. He's doing better in school. He was having trouble mixing with his friends, with his peer group. So mom said the neurologist can't believe the change and took him off of one of the medications, and they can't believe the change. Now, little aside on this, we sent them to ENT. ENT didn't want to do anything. ENT sent him for a sleep study, which of course came back normal. Well, I shouldn't say normal, came back with an AHI of 0. And I had prepped mom for this, and come to find out that exactly, that in the sleep study, when I asked mom about it, they woke Santi up at 4:30 a.m. to stop the test, which anybody who knows anything about pediatric sleep medicine knows that if they are going to have apneas and hypopneas, which they may not for a myriad of reasons, they are likely going to have them later in the sleep cycles in deep REM sleep. So Santi probably, between sleeping in this foreign environment hooked up to all these electrodes.
Exactly.
And waking him up at 4:30, probably never even got close to deep enough sleep to register as an apnea or hypopnea, if he would even had one anyway, of 10 or greater seconds. So anyway, this is all going on. Well, it's creating quite a buzz in the clinic, and the residents, we're all talking about this. Well, the chair finds out, and he is upset. This was my patient. Why did you transfer the patient? Not happy that I'm helping this kid. He actually the chair told me it was just an anecdote. It was a one-off, that there's no evidence. And we'll get into, you and I can get into discussion on evidence basis, but he and I had a little chat about that. And he said in an email to the residents and faculty that airway evaluation is not a reason to take a CBCT. So I pushed back and I said, I disagree, and went back and forth, and he emailed, and this is all in writing, and he said there's to be no more discussion on this topic. Again, very, very, very collegiate, down. Right? Very academic, right? In the spirit of, that's science. So I let it be known that I was not okay with that. And within a couple of weeks, I got an email saying, we don't need you anymore. No cause, no anything, no reason, just we're pursuing full-time faculty, so we don't need your adjunct role anymore. So this was in May, and it started a whole big thing. And it ended up, the residents were very frustrated by this because I had been really helping them with a lot and working on research projects and a lot of things with them. And it uncovered a lot of other issues with them. And they ended up being asked to leave. The chair and his wife, who was director, were actually asked to leave the program. And word is that they, from above, it got to the university level, it got high up. And again, this is nothing, I'm telling tales out of school here. This is all well known at this point. I didn't speak to it when it was going on because I just didn't want to get in the middle. I wasn't there anymore. I didn't want to be in the middle of it. But now that it's done, so they are not there anymore. So Nova's ortho program at this point has an interim chair who is a general dentist. They don't even have an orthodontist running the program. And they promoted a guy who is, I think, similar age to your dad. He's part-time. He's been there, wasn't there when I was there, but I guess he came back as an interim program director. So it's really sad what is happening in academia. And I tell that story, and I'm specifically not using names because it's not about the individuals. It's not a personal thing.
It could be any school.
Almost,
school. It's really widespread.
It's endemic to the profession and to academia. And I didn't even know. I was going to talk to you about that and tell that story for the audience. I just feel it's important to get it out there so people know just how much resistance. This all started over me wanting to take CBCT images to evaluate airway. And he said to me when we had the meeting about it, when I asked him why he was so opposed to it, he said, well, the gold standard of evaluating airway is nasal endoscopy. And I said, fair enough. I said, how many ENTs are doing nasal endoscopy on 5-year-olds, right? And isn't me looking at it with a CBCT better than just a rhinoscope to look up the nose? I'm not saying I'm diagnosing OSA. I'm not diagnosing even sleep disordered breathing. I'm diagnosing them with the signs and symptoms.
Landmarks.
Exactly.
That match the symptoms.
Exactly.
And they're orthodontic symptoms too, like narrow arches. It doesn't even have to be...
Yes. And why do you think? And I said, if it's anecdotal and empirical, then why, when you put a quad helix in on this same patient for a year, his bite got worse and his temperament got worse and his school performance got worse. And when I treated him with a different approach to expand the upper and lower arches and make more room for the tongue and develop the airway, and we sent him for allergy testing because he had turbinate hypertrophy and all of that, his airway got better within 3 months to the point that mom came in crying saying we were miracle workers. Miracles. And I said, if it truly is anecdotal, well, I know it's an N of 1, but you had a year with this kid and he got worse. Yeah. I had 3 months and we are transforming this kid's life. So that is the resistance. And that
so
clearly
many people can say that they had that miracle story too, which I think those of us who have been doing this for a while, this is not a one-off, as they might say, or anything. So
and clearly it was an ego issue with him that had happened, and it made the residents kind of question why he wasn't doing that. I get that, right? Even though I didn't make it that with the residents, I literally was just like, this is why I'm passionate about this. This is why I'm teaching this. And now you're telling me I can't even take, because of that, my punishment is I can't even take CBCTs. Like I do this amazing thing, teach the residents, help them, which I did in my practice all the time, all day, every day, as you alluded to, which is it's my why. And now I'm being told in an email that department policy is you can't take CBCT for anything but impactions or surgery or craniofacial. I mean, now the happy ending to that story, I've been asked to talk about, again, like you said, things happen for a reason, doors closed, so windows open. I was asked to run the orthodontic part of a new pediatric residency that's starting right near my home in Naples. I was driving an hour and a half to Nova each way. It's right down the road from my house. They recruited me. They knew who I was. They knew I was here. They sought me out to start and run the orthodontic component of this pediatric residency. So it's going to be, I think, an amazing opportunity. It's really exciting. They are interested in airway and whatever I can bring to the table to help them. And pediatrics, so we're going to get young kiddos. I know. So again, I miss the residents at Nova dearly. I love the impact I had on them. That's why I fought and even hung around to see if there was an opportunity once the chair and director were gone, well, maybe I can go back over there, but it's just, there's just too much resistance there still. The program's not in the place where I want to be. And so I need to move on. And this is literally, as we're having this conversation, this is all new this week in terms of me making the decision literally within the past couple of days that, nope, this is it. I'm going to move in the direction over here. This happened for a reason. And I'm going to be able to start something really cool. It's a brand new program. It's a privately funded program. It's not part of an academic institution. It's part of a hospital. So there's some Naples money behind it, which isn't a bad thing. And it matters. And so they've got a lot of resources, and they just took their first class in this summer. So I'll come in and I'll run the orthodontic part of the education clinically and didactically, which will be really, really, really fun.
Think of the timing, right? When you're you're on the verge of publishing a magnificent paper that's going to, there's no way this can't have an impact, whether immediate or slow drip, whatever it is, it's going to make a massive impact on the movement, the paradigm shift that we're all pushing for, really.
I hope. I appreciate that.
So what a great combination of things happening at the same time. That really is. See, things just keep falling right into the right place, right at the right time.
Yeah,
That's really fantastic.
It's so true. And that paradigm shift, well, thank you.
On both.
That, and I guess part of me is sad at just the state of orthodontic education. Like, think about that. Like, we now have a major orthodontic program where I'm not slighting the GPs at all in this. That being said, I think we could all agree that in a specialty program, you should at least have the person who's the specialist, like, running the program. I don't care whether it's medicine, dentistry. I think it's just something we would all agree on. Now, apparently, I don't know the gentleman. He's great. But the fact is, we're so big on this sort of ego of, like, I'm a board certified orthodontist, but yet we can't even find people to run these programs. And the ones who run it are so against this more progressive way of thinking, that paradigm shift. Why? Why do you think we're not doing better from an educational standpoint in our training for our especially orthodontic residents?
I think it comes down to human behavior. There's a fear factor. There's the behavior in crowds. What is that called? Mass
groupthink or
mass psychology, whatever it is, where there's a fear of putting yourself out there. There's the insecurity of not being the one to think of it first.
I heard from him, I've done this for 30 years. No one's ever questioned me like that. I'm like, right. Like, it's like, okay, but, like, to your dad's credit, as I said before, like, just because you've done it for 30 years doesn't mean you don't think differently.
We don't use leeches in medicine anymore. Like, that had to phase out and something else phase in as the science. And what is science anyway? Think about how many things we've read that are like, that's not appropriate, that are really not appropriate. You know, but the ones that are, we can embody, we can try, we can see in our own clinics how they're proven, as well as in the papers they're proven. We can be conservative, we can take sleep studies. I'm going to jump on a side note here with that sleep study thing.
Yeah, go. Like, I would talk about that.
I can't
because, go for it.
I get really excited. Yes, it's the standard of care. Yes, get some data for the before and after. But even if you're closed mouth, breathing through your nose all night, clenching and grinding, suffocating in a way, hypercapnia, having a sympathetic response with the masseter activation, I'm going to treat you the same way if you are closed mouth, clenching and grinding, that if you have apneic events 100 times an hour. I'm going to evaluate your airway, figure out where the obstructions are, make sure the right team is in place to address each and every one, whether it's orthodontic or merely a referral to ENT, whatever it might be. Addressing the situation is going to be the same, whatever the sleep study says. The sleep study it comes up with the numbers, AHIs and everything. You never talk about arousals. It's like, it's all, so it's good information. And what I like to do is check the data afterward. If we're going to, like, do something, say, how did we do? Because I'm going to treat you, you're suffocating right here, right now. The look of clenching and grinding, the sound of snoring, the sound of mouth breathing, the sound of apneas or the silence of apneas is all evidence of the body's screaming out loud, I am struggling to stay alive. Breathing is the most important thing we do. It is the most important bodily function. And breathing through the nose is the only way that our body feels safe doing it, period. And if we're ignoring any of that, we're not only not helping, but actually doing harm. Doing nothing is actually doing harm.
You mentioned about bruxing. That actually interesting in that thread in the doc community on Facebook that I was just referencing. That same gentleman said, bruxing is not a problem and is totally, I think he said completely normal or very normal, something like that in children. It is normal for them to brux. So I replied back and said, bruxing can be a sign of pediatric sleep disordered breathing, and that's very clear in the medical literature. And I sent him, I don't know, maybe 6'7". Do you know the little 6'7" thing? Do you have the 6'7's a whole thing with kids, and it's like a big social media thing. But so every time I say 6'7" now, I'm like, I realize how many times I say 6'7". But having teenagers, this is what happens. You get looped into these things. But so he was saying that in a child, it's not abnormal, or a child in the primary dentition, to see them snoring, to see them, well, actually he said snoring too, but to see them bruxing. And so I sent him, again, 6-7-ish articles saying, like, the medical literature doesn't agree with that. It's actually very clear in the medical literature that it is a sign and symptom of airway obstruction. Now, that was a couple days ago. I haven't heard back from him on it. Talk to that a little bit, if you would. What is that about, the bruxing and the airway?
It's the body reacting to a 911 situation. The body's chemical response to increased carbon dioxide, decreased oxygen, triggers the masseter muscles to activate. So now we're lying down. So we already have an obstructed airway, all right? Upright and awake. And that's what we're seeing in CBCTs too, by the way, is our patients at their very best. Just lie down upright against gravity. And lie down, the airway gets narrower. And then your muscles lose tone when we fall asleep, so it gets even narrower. Now the fluids can then fill up into the sinus cavities, swell up the turbinates, and because gravity pulling down when we're awake and upright creates because we don't have apnea or snoring when we're awake and upright, only when we're lying down and further when we're asleep. So when our body's perceiving that chemical change, it goes into emergency mode, starts moving that lower jaw around to open up that airway, right? I need to survive this breath right here, right now. I'm not worried about 5 minutes, 5 days, 5 years from now. There isn't 5 minutes from now if I don't breathe this instant. So that's why we're allowed or encouraged or required to take enamel, which is harder than bone, and reduce the vertical dimension of it, which what does that do for tomorrow night? It decreases the volume of the tongue. The tongue has nowhere else to go. Tongue goes back into the airway. We get an increased forward head posture, and now our body's even more related to it. The nervous system gets occluded, the posture changes. We have to make all sorts of compensations. So it becomes immediately systemic as well as structural. And then when our body's perceiving these events, we're not allowed to get into our deep restorative stages of sleep. So our body is then in this awakened,
like a sympathetic overdrive,
all night long. So tomorrow's behavior, we're going to be exhausted. Now you and I will have a cup of coffee, but we're giving our kids amphetamines, like you said, to keep. So we're like this when we're tired, head on the table, and kids are bouncing off the walls, but we both take an upper in order to get to a baseline of where we can focus. And all we really need is a good night's sleep.
And now do that every night for these kiddos. Every night. Like at least you, after that happens, you could sleep in a couple days later or whatever, or people could take a sick day from work or catch up on the weekend or take a long nap. If this is a child suffocating every night, they don't get to catch up.
No. And they don't, and they're told it's normal. So this is what they're going to learn that's going to be normal. How are they ever going to unlearn that?
Right.
And they're like, oh, so
as you said before, you'll outgrow it. You said earlier, we hear that all the time. What's that about?
Oh gosh, I mean, I think like the lengthening of the neck. We adapt well enough to it by
I know with the Scammons curves, people talk about, oh, well, when they get to be puberty, that the lymphoid tissue will shrink. I'm like, well, to suffocate between 4 and 12 is
cognitive development years.
Now so why, Liz, don't we even talk about, because I present to groups and different types of groups of dental and medical providers across the country. And when I'm in front of an audience, I always try to tailor my material toward the audience to some extent, where I meet them at their level and then try to push them a little beyond that to think a little differently on topics. Because if I talk if I go to a group of orthodontists and I'm going way in depth on this, and that group is not even thinking airway and ortho relate, you lose them. You don't,
Exactly.
It's not productive for anybody.
Exactly. Even if it's just from ego. Like,
even if it's just
I don't
from
know
ego.
enough in this guy's, right.
Like they feel threatened. So I'm always very sensitive to try to I want to always know who's in my audience. I want to tailor my presentations accordingly. But what's interesting is when I do that, I get to see, I love reading my audience and seeing how people are responding, their faces, when I'm saying certain things. And one of the things I find is that when I talk about the neurocognitive side, the behavioral side, the orthodontic arena by and large really clams up and gets somewhat resistant. You can see it in their faces. Like, what? Like mouth breathing causes brain damage? Give me a break. And I quote the medical literature of Bonnick and Gozal and Menzies and all these different studies I can quote. Yeah. And I'm like, what's going to be enough for you to understand that we're not making this up? And then I find what happens, and I want to hear your thoughts on this. Once I convince them that this is a thing, right? The neurocognitive and behavioral and even cardiovascular side of this, both short and long term, of airway compromise in young children, then the thought is, yeah, well, I'm the orthodontist. There's nothing I can do about it. So let's talk to those two hurdles. The first one being getting greater awareness in our colleagues as to why nasal breathing is so important outside of even just the humidification, moisturization, purification, pressurization of the air. And then once we can get them to acknowledge that, and this isn't just orthodontists. There's pediatric dentists, general dentists who are just as much in disagreement with this.
And then medicine.
And physicians, right, clearly, thank you. What do we do to help them see that we can actually do something about this?
Oh my gosh. Well, let me get my magic wand out. And But I think, kind of circling back to what we were saying in the beginning is that we're identifying all the blocks to it and coming up now with the solutions to it. So what are the solutions to getting this information out? We've tried going from the top down, right? Bringing it to the perceived authority of the AAO and
or the chair of an ortho department, as the case may be.
I mean, I can tell you about the ENT, the pediatric department at a local university. Oh my gosh!
Yeah, go ahead with your other topic. I'm going to have you come back to that because you mentioned that story to me, and it's great. I want you to share that. Yeah.
Yeah, that was funny. That's the thing actually is when I said that's funny, I meant it. We have to see this all with the grain of salt and with humor and with patience and with understanding that we're talking to humans with egos and fear and supported by an institution or something like that. That's where a lot of the resistance lies. Mm-hmm. I feel like if there's a way, whether we're going from the bottom up or the top down, if there's a way to, especially from the top down, and thinking like that, the authority of the institutions, the AAO, if we could introduce, this is my dreamy, like Snow White kind of version of all of this, but if they could realize that they would be the heroes instead of an antagonistic front that they're taking, they would be the heroes if they would recognize it and say, because what are they afraid of? Let's just talk about that for a second. Well, for all these decades, we've been treating it this way, and if we shift now, then what happens to the people we treated last year or in the 80s or in the 50s even? It goes into we were wrong. And it's like, well, it's okay to be wrong. Again, medicine is doing the best you can with the information that you have. When new information comes in, it's not a full pivot. It's just a shift in the way that we're diagnosing and the way we're treating. There's not much difference. What did you have to remodel your building and become something? Nothing really changed. You use the same brackets. You use maybe some different wires, but there's just a different approach to doing the same thing with a different why. The diagnostics are there rather, and the diagnosis includes the whole body, which, by the way, the whole body's connected to teeth. The whole body's connected to the tongue. The whole body's connected to the nose. Why are we isolating all 32 of these little guys as though it's that itself is a roadblock? But if the authorities could say, "Hey guys, we did the best we could with what we had." Hey guys, to the public. Yeah. Now we're gonna work in this with this new information, this new direction, and make a whole big marketing thing about it. Make it loud about it. Hey, we didn't know everything, and sorry, but you're going to be okay because we have solutions. If you want to go back into ortho, we can do it this way. Meet with your general physician, do it this way. Ear, nose, and throat physicians now need to get on board and do it, treat the nose. But if we make the announcement, then everything snowballs into demand for the other disciplines to get on board as well. It would be, look, remember I have a degree in PR. That would be if I were in charge of AAO PR, this is exactly how I'd go in and say, you guys want to be heroes, not considered the naysayers, the hands up in the face of wellness, the hand to the face.
Yeah.
Wellness,
and we're so worried about the GPs doing Invisalign, right? Or clear aligners.
Yeah.
It's like, we wouldn't have to worry about that for a second if we embrace this earlier airway-focused proactive treatment approach.
Yes.
We are the experts in craniofacial growth and development. I have had so many general dentists and pediatric dentists on my show who have said, I didn't want to do this, meaning airway-focused care. They're like, I've got like a full practice running, doing no orthodontics at all. But once I started learning about this and seeing that realizing I was seeing these young kids, detecting the signs and symptoms of airway compromise in them, I couldn't not address it. And I kept, listen, a number of times I've heard this, I kept sending them to the orthodontist and they all kept saying they're too early to treat, or they'll outgrow it, or we just wait and watch. There's no need to treat these kids that young. And I actually think when I spoke at Airway-Palooza recently, I talked a little bit about this. And one of the things I think that is causing that is we didn't learn this in our residency, not only from a didactic standpoint, but we don't treat young kids in residency. In fact, some people may be surprised to learn if an orthodontic resident graduates, now they have gone through 4 years of dental school, and most programs are now at least 30 months, if not 36 months of an orthodontic residency. We'll just call it 7 years post-college. If they've gone through that much education and treated on average, and I speak to residents all over the country, most of them, if you say, how many patients have you treated under the age of 10? It's less than 5. Some it's none. So, and it goes beyond the scope of today as far as why that is. It has a lot to do with, just a kind of scratch the surface. It's just the fact that there's a lot of state funding in the patients who are seen in orthodontic programs, and because of the Saltzman Index and the medical necessity, they don't cover us to do proactive treatment. Again, reimbursement, right? The treatment follows the reimbursement. These patients are on state funding. They can't pay out of pocket. In a lot of these orthodontic programs, when you see a kid at 6 with these problems, you have no choice but to pull teeth because the teeth are impacted, they're crowded, they're narrow. But the state won't cover you to do anything unless there's a crossbite or a craniofacial anomaly that can be labeled. So when we see
tooth-related
totally
issue, like
tooth-related. Yeah. So they come out and they've never done this. Yeah. We've been trained to be really, really good tooth straighteners. So I guess it's not a surprise, or shouldn't be a surprise, that we want to focus on being tooth straighteners in our practices. And when someone like you or I comes in and says, hey, look, you could do this in, say, 6 to 8 year olds, and even 3, 4, 5 year olds.
Oh, yeah. You're never too old or too young to start breathing.
Right.
Never.
You've got a lot of great. That's great. And it's so true. And when you say that, and then someone to an orthodontic colleague say, or again, it doesn't have to be an orthodontist, because it's not just the orthodontist. There's plenty of our dental colleagues and medical colleagues that feel this way. There's a lot of resistance from everybody. The orthodontists get labeled as the only ones that are obstinate, but it's not true. It's really the profession in general. When you tell people, geez, maybe in 3 to 5 year old kids, there's a lot we could do. Whether it's like, it's not that they need necessarily orthodontic treatment in the sense of what we think of it as, but growth guidance, myofunctional therapy, right? Yes. Making sure that we work with medical colleagues to clear up any obstructions to nasal breathing. Yes. If there's a tether, right, or a tie, and releasing tongue, allowing for appropriate amount of tongue mobility. All of these things that we could do in that 3 to 5 age range. When you talk about that, what is the basis of the resistance?
Yeah, it's an age-old taboo to be considered someone who treats phase 1. Remember that argument? Do you ever do phase 1, or do you do it all at once? Phase later.
It's funny you said that, because in my talk at Airway-Palooza, I quoted an article from Orhan Tunkay in 1993 in AJODO, where he said that anyone who was performing proactive early phase 1 treatment, He wrote a whole article talking about the origin of the term quack. And how it is. I'll put a link to it in the show notes just because I think everybody should see it.
I want to see it.
And he said there's two groups of orthodontists out there.
Yeah.
The good guys, right? Those are the ones that perform orthodox treatment that's based in science and data and evidence. And then the bad guys that are practicing what he calls unorthodox care. And he calls out those doing early treatment, as you just alluded to, doing more phase 1 as charlatans, quacks. And that was 93. And you really saw Orhan ran 3 orthodontic programs, like Kentucky, Mississippi, Pennsylvania, don't quote me on the exact ones, but 3 programs. And he was well known in the profession. He was I don't know if he was an AAO president, but he started multiple journals in the profession. He was very, very educated. But one of the things I showed in my talk was, interestingly, on his website, if you go there today, it actually says that he was the creator of Invisalign. Now, our colleagues like to use randomized controlled trials as the barometer for evidence basis, which is not true. That is the highest level of evidence, but one does not need a randomized controlled trial to have something be evidence-based. David Sackett talked about this extensively. He is the father of evidence-based medicine, so to speak. And he actually, the term was coined in 1991 by a gentleman named Gordon Guyat, who was a disciple of a student of Sackett's. But Sackett wrote a paper in 1996 British Medical Journal where it's called Evidence-Based Medicine, What It Is and What It Isn't. And he literally says in the paper that it is not restricted to randomized controlled trials and meta-analyses. That if an RCT has been carried out for our patient's predicament, or if it has not, you have to follow the trail to the next best external evidence and work from there. If you don't, the practice risks becoming tyrannized by evidence, right? And he actually says it's a bottom-up approach that integrates 3 components: clinical judgment and expertise, relevant scientific evidence, which would be the data or the research, and the patient's values and preferences. And that those 3 circles, like in a Venn diagram, are all of equal weight, and where they intersect or overlap, the confluence of those 3 ideas is where evidence-based practice lives. Yep. So we are told by our colleagues, such as Dr. Tung K, that, and this isn't personal against Dr. Tung K, I don't know the man, I'm literally just going off an article that he published. So I have every right to critique an article that he published. This isn't me hating on the guy, and what's on his website, right? Yep. He's putting this information out there. Yep. He has to be willing to take the feedback. So he writes this article in 93. Well, he was saying essentially that what we're doing isn't evidence-based by doing this earlier treatment. Okay. Was Invisalign evidence-based? It was developed by 2 Stanford MBA students. So I'm not sure why it says on his website that he was the developer of Invisalign. I don't know. I don't know the specifics, but I do know it was developed by MBA students at Stanford. But let's just go with it and say he was like a super early adopter.
Sure.
Liz, it was developed in the 90s, the late 90s. The first randomized controlled trial on the safety and efficacy of clear aligners was 2015. So more than 15 years before there were any sort of... So in other words, I think it's fair to say that Invisalign in the late 90s was, quote unquote, quoting him, unorthodox, right? Moving teeth with plastic was unorthodox at that time. 5 years earlier, he wrote an article saying anybody who is doing these treatments... So again, you see the hypocrisy of this. It's just time. It's hard to even comprehend, but I say that, I tell that story because you brought up such a good point, and I hear that all the time, and I agree. Something in the 90s and then the early 2000s, Gianelli, we were talking about him before we hopped on. You trained at BU. Brilliant guy. He wrote articles in the 90s and early 2000s talking about there is no need for interceptive treatment in more than 90% of the cases. But what did they all talk about? The teeth. Mm-hmm. That's it. It was literally like, oh, you can save e-space or you can start.
And I agree if they were just looking at teeth that it might not, like we can, those articles are good if that's all you're looking at. But you've put the teeth back in the body underneath the airway and in front of the airway, and you see the whole domino effect of anything that's the evidence that we see in the mouth, and you see how much of a requirement it is. What I would say to patients or anyone, if I was having a lunch and learn with another dentist or medical or whoever, I would say phase 1 treatment is the medical portion of orthodontics. This is where we're treating.
I like that.
And prevention. It's like, this is the medical part. Because then when we encourage the development as early as we can or see fit, or when it's acceptable case by case basis, then once we have the established airway, they have the best chance of growing themselves into a minor orthodontic issue later. So it's a medical portion of orthodontics in phase 1, and then you do the orthodontics later. And I say, and that's just putting up the curtains and making it all pretty at that point. But the medical portion is what I now see as our phase 1.
I completely agree with you. And the ADA has been good on this. Guys like Steve Carstensen have been amazing fighting for this. The AAO needs to step it up, because this would be a lobbying change that's needed to the politicians. They would be heroes. So if the AAO started to say, hey, look, we could save the medical system exponential dollars. They could run the numbers, because studies show that upwards of 50% of patients who have an ADHD diagnosis, which is a subjective diagnosis, with the Conners rating scale is usually what's done, have an airway problem. So just look at, let's just say half of the kids like that, we could solve the problem of their ADHD, take them off of some of that medication, which is a burden to insurance benefits, right? Plus the time missed parents out of work dealing with managing these issues. Then you add in the neurocognitive issues and the special education treatment and all of the things that these kids are going through. Then you get into the cardiovascular comorbidities, and then take it to the next level of adult sleep apnea and all of their complications and the car accidents and the cardiovascular, the psychological implications of these people who are going through horrible times in their lives because of
anxiety, depression.
So if the AAO, I love what you said, they could be the heroes. Like, we are going to tell you that we have the ability to go in, look at us. Like, again, you know how I mean this, and the audience will as well, but most orthodontists aren't exactly shy in the ego department, right? And I put myself in that too. When I was practicing my community, you're proud, you're talented, you've been at the top of your class, you've pushed hard, you've achieved, right? We deserve to be proud of who we are. We could own this at a level that we can't even comprehend, but we would have to get to the medical insurance side.
We immediately put dentistry on the top of the pyramid, so to speak, of medicine.
Yes.
It's like, it's a no-brainer. It's I don't know, but all you have to do is just see it from it's a perspective. You got to just see it from a different angle,
right? Which
is the most obvious angle, if you ask me. I can't help but see things that way. It's in my nature.
But I feel we have to get coverage. We have to get health, because again, I keep saying it, but sadly it's a reality. The treatment follows a reimbursement.
That's reality.
I say all the time when I speak, and I've said it on this show, if all of a sudden, I said it relative to the ENTs prior, if all of a sudden they started reimbursing $4,000 for early interceptive orthodontics before the age of 8. Can anybody tell me that we wouldn't see a lot more early interceptive orthodontics going on out there? I mean, come on.
Heck yeah.
Right?
Absolutely.
So how do we do that? How do we get the medical community? Because I agree. I don't think the dental insurance world is going to necessarily be the ones. How do we get the medical community to start to get on board to try to reimburse some of this stuff, a la Peter Attia, proactive treatment? I call it Ortho 3.0, right? Not waiting for the problem. Because I think that's at the crux of, I feel if we solve that, we can really shift the paradigm.
It's going to be slow. But you know what? Galileo was dead before they figured out that everything he said was right. So it's going to take time, and we just have to have our patience along with that. You know, and even in this information age where everything is travels in an instant, it'll probably be faster than it would then, but I still think it's going to be something that takes time. There's so many the different angles we were talking about, working with a physician, but it puts so much weight on the individual orthodontist in our own communities to not only educate patients one by one, but educating our local team or local antagonists, however they are at the moment, universities. I mean, people who have a foot into universities like you see how you did it from the residents up. It still had to go from the whatever institution, whether it's a community institution of a community or institution of a university or an association. It seems to still at the moment be from the bottom up, but there's going to be what is it, like critical mass at some point.
Right, it has to reach critical mass, and I think the parents are a big part of this too.
Yes.
Right?
Yeah.
We need them to advocate.
Yes. And we need to have a way, and this is going to get a little bit into what the project is that I'm working on right now. And let me just say, like, I do not mean this as any kind of advertisement or anything at all. Like I've been, as you have, as we all have, everyone who listens to this, we're all going, I know, yeah, me too. We all are on board with the struggles that we're facing. Well, having sold my practice and put all my attention into finding these solutions, I'm putting together a platform where it's going to answer some of these. It's going to answer as much as it possibly can by helping those doctors who are curious become more educated. And I mean providers, actually. I'm not focused on general dentistry, orthodontists. It's going to be for everybody who's curious to find some education, ways for those of us who are well educated in airway already to help others in the community get educated, having things be tied up in a little bow so it's easier to communicate to someone in our neighborhood or in our university or in another institution to hopefully give some credibility to that. It's going to help not just providers, but patients learn, so it can ideally save time for the provider. Because remember, you were talking about this I didn't want to become an airway advocate. I didn't want to become an airway. It screwed up everything. Like my consultations, and my dad's especially, because I was right there at Airway in the beginning. So my consultations go from 10, 15 minutes to an hour, because you have to explain the whole body to everybody.
When I said it, that was some of the things I talked about Airway-palooza, of the obstacles, time being one of them. Thank you for bringing that up. Like, we run these, and people may not realize this, but as an orthodontist, and we've both been busy orthodontists, and I didn't do airway early in my career. I did a lot of early treatment because I just knew the teeth I knew big teeth wasn't the cause of this.
It didn't make sense.
Like, I'm seeing a 6-year-old, I'm like, your teeth aren't big. Why?
Small jaws.
Clearly I can see, I'm trained. I can see it's small jaws, not big teeth. So why don't, I've always been about just philosophically, fundamentally about treating the etiology more than the symptoms. So, and that alone was a strain on the practice because I started de novo, I had no patience, so I could do what I wanted. But as I got busier and busier doing all that phase one, it becomes a drain on your practice. It's it's time intensive. And I wasn't even doing the airway part yet. I was just doing upper and lower fixed expanders, some brackets in the incisors. Yeah, good. Which is what led me to do it without expanders, because it was much more efficient. But then I got into the airway side, and Liz, you're so right. All of a sudden, what should be this quick consultation, and we're taught by our consultants in our arena, right? Like, hey doc, get out of that room 2-3 minutes because you're going to say something stupid, and they literally say this, or you're going to open up Pandora's box and they're going to start asking questions, and you're not going to be able to get back to the clinic where you make your money. And so if we're trained that way, we run these hyper efficient practices that aren't built on us being in that room for even probably 15 minutes for most people. We don't have the intake form systems to be reviewing the histories. We don't know how to communicate about all of this. And I talk about this because this is a big obstacle. It's really big.
It's the biggest. And I'm so excited. Like, I want to just tell you everything, but I have to keep it under wraps until it's ready for launch, which I expect to be, I hope at the beginning of the year. But I know that. I lived it. I've breathed it, no pun intended, that problem over and over again. And so I've created what I believe to be the solution for it.
Oh, that's awesome.
I really, really do. And it's something I'm making very available to everyone, so that it's something that all providers can implement, and patients will be empowered when they come into your practice rather than needing the convincing. Like, it's a whole different way of having this introduced. So everybody wins with this platform. So there's even more. There's going to be resources that providers and patients can both have, to whether it's to learn, whether it's to gather data to help teach other people. Like, wouldn't it be great to just send an email to the ENT and be like, here you go?
Yeah, because that's another thing. We don't know how to communicate with we're not taught in school to communicate with medical colleagues.
Exactly.
We don't learn this.
And here's the information. I'm going to lead you to water. What you do with it now is up to you. And gosh, we really hope that they drink. But there's some credibility behind all of it. And the more people that get involved with this platform that I'm creating, which I think is going to exponentially just be a natural thing that people want to do because it benefits everybody. So it's also going to be a place where, so it's gosh, here I'm going to say the name of it. And again, I'm so sorry. I do not mean to sound like I'm advertising for it at all, but like I just want to help, and I want to give everybody everything. And so this is the way to do it. It's called AirwayZ, and it's airwayz.com. And my tagline.
And I can put a link to it in the show notes too. Please
do. And right now it's just a simple landing page, but please put your email address into it. I'm starting to get some previews going out for those who are signed up and whatever. And then so my very clever tagline for AirwayZ is everything airway from A to Z.
I love it. I love it.
But I want everyone to be able to have a place where they can find everything, find each other. Because how many times do you have a patient that says, hey, my sister in Arizona needs some support, and you're like, all right, I'll spend 45 minutes looking through people who
all the time.
Everyone says they do airway, but are they actually qualified? Do they have CBCT? Like at least they're looking 3D. You're trying to find. Well, I'm trying to create a way where that becomes seamless for patients to find other people, providers to find other people, find evidence, find education, just to simplify, and a way to communicate. This is an interdisciplinary problem, and we need all the disciplines to be able to communicate with each other too. Wouldn't it be so cool if an ENT was like, hey, that sounds really neat. We should get together and write a paper on that. Or would you like to speak at the otolaryngological meeting?
And that's actually a goal of mine for 2026 is I want to speak. I've been at a bunch of engagements this year in 2025, speaking at many different types of dental related meetings. I want to start speaking more at medical meetings because we keep saying we, the collective we, but I am pointing a finger at myself because I do say this, that our ENT and our medical colleagues and our pediatricians need to understand this more. But what are we doing to educate them? Again, I'm talking to myself with this too. I'm in this. This is what I do. And I'm not actively reaching out to them to help them learn more. So I need to step it up, and I need to do a better job of actively reaching our medical colleagues, because I hear that all the time too from people. They're like, I finally started down this airway journey. I get it. I've done the research. I understand it. I'm really moving in this direction with patient care. Yeah. But I detected a problem and I sent them to fill in the blank medical provider, and they said it's nothing, or they can't do anything. Or
how about this one? Concha bullosa is a normal variant.
Normal variant. Yep.
Or
Yep. So I've got some strategies, which I teach and my content is taking screenshots of your 3Ds, or if you work with a 3D software company that has a cloud basis to it, you can email it through the cloud, secure, HIPAA safe transmission, encrypted. They can download the 3D image, but it is incumbent upon us to communicate better with our medical colleagues. You have to send letters. You have to send images, and don't write a 3-page dissertation, please. They are busy. They are preoccupied. Bullet points, summaries, points, what you're seeing in these patients, turbinate hypertrophy, obstruction of the adenoids, tonsillar obstruction, hypertrophy, level 3 tonsils, some couple clinical
befores
pictures.
And afters.
Right. That's all you have to do. And knowing a lot of them are not doing endoscopy on these young kids, especially if you have a CBCT, even if you don't have the ability to transmit the full image, and we used to, before it went cloud, with iCat, we would actually give them the CD, but that not every office they take it to can open the CD. There's a lot of virus restrictions. At the very least, take a couple screenshots, train your treatment coordinators, take the screenshots, throw them in the letter, and send the letter with the screenshots of the coronal slice showing 80% obstruction in the nasopharynx, and give a sagittal slice with the crosshair, so to speak, in your 3D, right in that nasopharyngeal area, in the area of the adenoids, and showing the obstruction. They can't ignore that. If they just look up their nose with a rhinoscope and say, they'll outgrow it. But now, because what happens is, and it sounds like you're looking to do more of this too with your platform, we have to give them, unfortunately, some sort of feeling that there could be liability if they don't look into this further. So in other words, if we just send them off to the ENT and tell them, well, you should get your adenoids looked at, better than nothing. Right. That being said, you have to do two things. You have to educate the parent as to why this is important to look at, and you have to educate the provider as to why you're concerned. But Liz, that goes back to what we started by now. So you're telling me, Liz, that I've got to now spend, let's even say 15 minutes, because that's a lot for an orthodontist in the consult room. Plus we've got to send letters and we've got to follow it up, and my TC's got to, and then the parents are going to
I'm burning out just thinking about it. I'm burning out all over again.
Right.
Just thinking about it.
I mean, truthfully, it's real. And
that's what I'm aiming to solve, though. Okay. Exactly. Because literally, great. Like I did it. I got to the point of burnout, and we just realized like we can't stop doing this, but it's like the challenge of pounding the pavement with other doctors and convincing every patient every time they come in. There is a massive burnout factor. Or even as many times as I love sharing with somebody what they're about to have is a massive revelation of how everything in their body is connected, and it's probably related to their nose. Mm-hmm. And that's why you're here at the orthodontist is your nose. Like going through that whole cascade of relationship, you still burn out. You still have that whole burnout factor. Yeah, because you do it
all day. All of a sudden, these people, right? They start calling. More people are calling you for that service, and because we care, you can't stop. You can't stop.
Yep, you're on overdrive, over time, over everything, and that's the thing. What we need to do, and what we're doing, you're doing with your podcast, and what I'm doing with this platform, is helping preserve the energy of these doctors, because we can't have our dentists and orthodontists who are practicing this way, we can't have them burn out.
So true.
Right? The flame goes out before we're actually out there. It's so true. So I want to support the ease of that, make that job so much easier. So either you see more consults with this more time, or you go home. You spend time with your family, like whatever you want to do with your free time that you're going to gain from this without taking away because there was something I really loved. There was something that lifted me every time I was able to share this with a patient. The why comes out, and it doesn't take that away whatsoever. It just allows you to get to it without doing the scripted part over and over and over again that you do. And now, so here's the basic
streamlining it essentially.
Exactly, totally streamlining it. And which you can make more money, or you can not burn out. You're going to get more referrals. It's a win-win-win-win-win for everybody. It wins the practitioner, the patients win with this, and then the community wins in a very evidence-based way where everyone's given the resources to make this a lot easier for everyone so that the world can get better a whole lot sooner.
No, that's awesome. And people think, you brought up the money of it. Number one, we all run businesses. We have to be profitable, right? Unless you're running a charity or a charitable organization, which is great. It's just most of us in our private practices are not. That doesn't mean we don't do charitable work. It just means that we have to have a profitable business, just like an ice cream shop or a hospital.
I gave so much away.
We do. And we have to have certain amounts of profit margins. But the biggest myth is that airway-focused care is like this scam to make more money. Oh. I actually think it's gaslighting because at its finest, because honestly, it really is. To me, it's the people who want to keep charging the higher fee to straighten teeth in adolescence. They don't want to compromise that income to start charging lower fees oftentimes to do proactive treatment when they're young. It's another obstacle to it.
It's easier to stay in your comfort zone.
It is.
Like, this is my routine. I know this. I learned this in school, so nothing else can be right. And I have a system. My staff does it right this way, and I make this amount of money, and whatever it's all.
You're comfortable.
It's a comfort, and that's the human nature part I was saying. That's where the lock is. It's like, let's see the collaborative. Let's see how everybody wins, and we're inspired again to do, maybe for the first time, to be passionate about something we do rather than comfortable in our routine.
Yes, and that's why I feel a lot of orthodontists don't want to, for all of those reasons, and they're not knowingly doing harm, right? Like I always say, I feel like orthodontic colleagues, and I shouldn't say no one. I don't feel there are a significant number of providers, right, who are intentionally trying to put blinders up on airway because they want to harm patients. I really don't believe that. I don't. I don't think we'd be in this profession if we didn't have some desire to help people at some level.
Right.
I feel like that's part of why there's such resistance, and they have to name call and label and call it quackery when you open this arena to them, because and they don't want to think that they're actually causing any harm. that's a really hard place to be, right? And especially if you've treated your own kids, your grandkids, your friends' kids, your nieces, your nephews, like that's a really hard headspace to be in, to think, oh my gosh, like how many people have I actually not knowingly, unintentionally, right? We're not saying you did anything wrong intentionally. It was what you were taught. Yeah. We need to change, because in 10 years, I don't think that grace is going to be extended, and probably shouldn't. But where we are now in late 2025, most people can look at that and say, you did the best you could with the knowledge and training you had. Bingo. Now it's time to think about it differently. And it doesn't make you a bad person or provider. I do think, though, that is something that's really challenging. You know, we've listed so many of these challenges. I actually think that might be the most profound one, is to look back at your body of work. And it's like, Liz, I'm a board certified orthodontist. I'm a really highly respected member of my community. I have financial success. I have this great practice. I look at my wall of smiles behind me, of all these beautiful smiles I've created. Mm-hmm. You're going to tell me that I'm not doing this the right way? Again, it's that Dunning-Kruger curve.
You're drawing an exact parallel to an individual orthodontist as you are to the entire establishment of American Association of Orthodontists. Yeah. It's an individual issue, and it's also the core systemic issue. Yeah. How many patients have I treated? How many patients have orthodontists as a collective treated under the guidance of AAO? Like, the pivot is massive for one doctor. You're saying it's exactly the same thing as the problem with the AAO. Yeah. I mean, literally, when I came home from the course that I took, the first airway course that I took was actually Steve Olmos in San Diego, when he told us all about the airway. I came home after the weekend course. It was several weekends, but the first patient I saw on Monday morning, it was a 4x extraction case, and they were there for an appointment to check everything before D-band next visit. I literally sat down and was like, what have I done? Yeah. And like the solution to that, and I remember asking all of the airway teachers, what do you do? Like, literally, there's so many patients today. When I was first learning, today there are patients that, with the knowledge that I have now, I know I would have done differently had I, and you do the best you can. What I did with them was I gave them a very airway nervous system, orthodontic designed sleep orthotic to maintain their airway, since I probably took a little tongue space away, you know?
Or at the very least didn't make them more.
I didn't make, exactly. Right. And so, and I, you do the best you can, you finish your cases. If there's an opportunity still early enough to pivot in the plan, that's where I pivoted. But there's that moment where you haven't adopted the new, and you recognize that this is now old, where you have to start just making a shift, and you love yourself all the way through it, saying, I did the best I can. I forgive myself, but like, do the best you can to somehow, like, I didn't just give them retainers and finish them. I couldn't. I ate the cost.
That's admirable. It's hard.
The retention as a sleep orthotic. And then we took 3D at that point, and if applicable, they went to the ENT, and we did the best we could. But it was a scary Monday morning, I'll tell you that.
Yeah. And on that, I want to just state, and then I want to finish up by you telling that story, because I promised I wanted to come back to that. I'm going to finish with that. But I'm really trying hard when I teach, coach, speak, to get this away from a debate about even phase 1, phase 2, but or phase 1 or no phase 1, extraction, non-extraction, right? We have to get away from, I say all the time, it's not like someone walks into the oral surgeon or whoever's going to pull their teeth and breathing perfectly and walks out less 4 premolars and has sleep apnea or has obstructive airway. Like, it's not about pulling the teeth. No. And in most of these patients that you pulled teeth in, they didn't have enough tongue space to begin with. Right. They were poor breathers to begin with. Right. You just treated the symptom, not the etiology.
Treated teeth. You treated everything I learned in school.
You waited. You did watchful waiting. You let them hopefully grow it out and said, oh, there's not enough room for the teeth. We're going to pull some tooth mass.
It was A+ in the standard of care.
Well, it's our boards still to this day. We've got to have these cases. And they're not looking at this from a proactive standpoint. Right. And the problem with that is it's gotten twisted into this whole, like, show me the evidence that extractions cause airway problems. And I'm like, no, we have to stop going down that path.
Stop being so narrow.
Yeah, it's not. That's why the literature and the data aren't there to prove it, because they had the problem first. So So how about we look at how many people that I treated young end up with an airway problem versus how many people you didn't, kind of like that one I was talking about with the chair of the program, right? Like there's a way to start to do this. And so we do have to collect more data, and that gets again beyond the scope of today, but we've got to start to be able to have that data. But I really want to shift that argument away from, this needs to be an argument over, it's about what I call ortho 3.0. 2.0, a la Peter Attia, is the reactive, tooth focused, straighten the teeth, try to make them look good, make those models so that they sit on the table beautifully, or your 3D of your occlusion. Ortho 3.0 is a patient-based, holistic, proactive, growth and development focused, airway-friendly approach to orthodontic treatment that looks to prevent as many of these issues from occurring as we can. And we can have all the arguments we want over extraction and non-extraction and phase one and not phase one. It doesn't matter. At the end of the day, that's technique changes. We need a paradigm shift. That is, do we go from reactive tooth straighteners to proactive, holistic, treat the entire patient providers, healthcare providers? That's, to me, what it's about. But I finish up with that story because I've heard it and it's great. Okay. So,
all right. So I just opened up my practice at the time in the Burlington, Vermont area, and I was pounding pavement. I'm going to go up there and save the world. Vermont's going to breathe. They're going to be so accepting of my mission. And I had this, whatever, I will always have a little fantasy of everything being perfect, right? Yeah. So I was speaking to a doctor through a dentist who got immediately on board and was having these little meetings. And he said, I know the chair of the pediatric department at the university. And I'd love to set up a meeting for you. You can get grand round, talking about all sorts of possibilities. And I'm like, yeah, okay, I can, this is great. You're going to change the world. So I sat down with him at my laptop and started going through a little slideshow that I had put together with a lot of pictures, some titles and claims and befores and afters, just what I thought was a real easy, impactful way to get the point across. And he stopped me on slide 4 or 5. He's like, this isn't appropriate. You can't just make these kinds of claims. You need evidence to back it up. And I said, oh, well, and I pulled out this memory stick and put it in the computer. I said, this is for you. I've compiled all of these for you. And I didn't start with that because he wanted you to see the reason why you want to look at these articles. Well, these have to evidence-based and they need to be the peer-reviewed articles. Sorry, I have to backtrack a little bit. I found out that he was the editor-in-chief of Pediatrics magazine. And I literally went, why don't we look at this one? And I opened up one of them that was published under his approval in Pediatrics magazine. And there was a little, and I said, why don't I just leave you with this? I see I've taken up enough of your time. And I was right, but right or wrong, I never heard from him again. And the department was very resistant to it. They would, but you know the stories. They would roll their eyes, comfortable. My patients would come back from those appointments to my office and they say, I left there in tears. They didn't even want to listen. It was a whole, it was shameful. And so that changed my script because it would continue to happen had I still been practicing. And I say, no, listen, they're not on board with this. And it said, it's with all respect, they didn't learn this in medical school, just like we didn't learn this in dental school. So grain of salt when you hear the nose doctor who might say there isn't an issue with your nose. That's why I'm asking you to drive 300 miles down to Boston and see this ear, nose, and throat physician. But if you can't do that, be prepared and try to prepare them. I'm like, they might say I'm that Q word. They might be calling me, in fact, rolling their eyes. Oh, your orthodontist sent you? In the faces that they make and shame the patients for even being there, talking about something that is crystal clear as an issue with their gaping mouths and they're saying there's no problem with your child's breathing. I mean, I'm preaching to the choir, you get it. But
no, but it's good for everybody to hear that. I like that story because it shows what we are up against. And I think it helps everybody to know, because I get asked all the time, why are so many people so resistant to this? And so it was really helpful today to dive deeper into that from two people who have lived not only the journey personally of going through all of this, we've also lived the journey of fighting to try to raise more awareness to this. And those are related fights, but they're separate fights. And we are both people who within our respective communities, when we were practicing this way, had a lot of people using the Q word or saying that there was no evidence basis or science behind all of this. The irony is we are actually the ones with, when you know the definition of evidence basis, we are the ones with it. As I've said many times, by their definition, anybody who used clear plastic to straighten teeth prior to 2015 technically isn't using evidence base. Again, I'm not saying that's the case, but per their definition. So we know the challenge. That's why I try to put shows such as this out there with colleagues where we can just discuss this and the audience can hear what you and I talk about anyway, because there's a lot of people out there who are like you and I who are going through this. They feel lonely in their own communities. They feel isolated. They feel crazy that they're the only ones doing this and everyone's telling them. Real. And they're worried too about liability. I know people have been turned into state boards for this stuff. So it's very helpful, I've found. And people come up to me when I speak and they will tell me certain parts of the show that they really love. And one of them is just feeling like they're not alone.
You're not alone.
And, right? And
you're not alone.
Send this to colleagues. Like, this is an episode of two orthodontists who have been there, done it, talking about this. If you have an orthodontic colleague who's resistant to this, or a medical colleague who's resistant to this, send them the episode and just say, listen to this for a little bit. Just hear what they have to say. And then they can dive deeper. And we didn't dive deep into a ton of the evidence or medicine side of it. We can, obviously, not for this show, but that can certainly, and everyone can reach out to me if you want more evidence or data on things. I have it all over the place, right? And same with you. It's
if you have an orthodontist neighbor that is resistant and is open to a phone call, have them call me. I literally, I have the time now, so I have the bandwidth now to be able to really have those conversations, because we can relate to that immediate commiseration of like, oh my God, this is going to ruin my practice. What do I do? Like the fear of what
do I do with all those 4x cases running around my clinic?
Yeah, it's real. Right. You acknowledge
it's real.
You just have to move forward with what you now know. And it's harm if you know it and you don't act on it at this point.
I'll let you have the last word with that. I love it. So how can people reach you if they want to get in touch with you?
My direct email is liz@airwayz.com. The business email that also comes to me at this point is breathe@airwayz.com.
Okay.
Clever. And there's it's not quite published yet, but there's going to be a phone number that's on the website when that's launched. Like I said, I hope it's early in the year. But and I'm always open to conversation, feedback, commiseration, helping anyone. I'm in. All hands on deck. I'm in.
I appreciate you and what you're doing with this. It's not easy. I know from fighting this fight alongside you from the other side of the country, or the other part. You're at the top, I'm on the bottom here, but it's not an easy fight, and it needs to happen. And it's really something that's hard to happen when you're fully immersed in a private practice, because just doing it in practice is so draining and time consuming. I just give you tremendous credit for being willing to step away from that to go do something on a greater and grander scale and be able to try to change the way our profession views this, and the way not just our profession, but all of medicine and dentistry view this issue. This is the battle of the future. This is what needs to happen. So thank you so much for sharing openly and honestly, and for all the work that you're doing. Really, really appreciate it.
That's my pleasure. And the same gratitude right back to you, Mike, because without you, then this information, it circles right back. So thank you right back. It's truly been an honor to be a part of this, and I look forward to our next interaction.
Yes, same with me. So thanks so much, Liz. It's been great. Appreciate it.
Thank you. All right. Bye-bye.
Bye. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses, or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.